дорогие друзья. Меня зовут Анастасия Петрова.
Good morning, everybody. My name is Anastasia Petrova. I'm a director of one organization, and I will be leading this session. It is an honor to greet you. And today we will speak about mental health and HIV. So first, I would like to highlight some logistics issues. We will have interpretation to several languages. So in order for you to choose your language, you should choose the audio channel. And then you can choose the language of your choice. The session will be translated into several languages. There will be a small delay. Today, we will have several speakers. Half of them will be speaking in Russian and the other ones in English. So let's hope there won't be any problem. Just choose your language. I would also like to highlight that the session will be broadcasted and will be safe. So it is important to remember that if you want to share some confidential information while doing questions, it is important to remember that. It is also relevant to say that you can share, if you want to share it in a big scale, take it into consideration. There will also be a broadcast in Zoom, Instagram, and Facebook, so we can say that this is a broad audience that will be seeing this session.
Здесь выведены на экран правила, да, я думаю, что вы с ними познакомились. И я немножко скажу про то, что сегодня будет.
So I hope you were able to read the guidelines in this previous slide. So now I would like to tell you what are the main topics for this session. It is a great honor for me to include the presence of a doctor as well as representatives from several communities and from the communities of people who live with HIV and for those who live with psychiatric disorders also. The moderator of our session will be Svetlana. So I'm so grateful that she participated as a moderator for this session. It is also, well, in that sense, it is an honor to give you the microphone, Svetlana. Good morning, Anastasia. Thank you for that great introduction. So now I take the floor. And I just want to mention that this is a very important topic for me at a personal level as well as a professional level. Speaking about mental health, because I'm a person that lives with HIV in the last 22 years. And I remember when we were just organizing the first organization with people living with HIV in Ukraine. So we started with self-support. Self-support is the basis, or this is the foundation for any other type of support given to people living with HIV. Because the acceptance of the diagnosis is really important, mainly in those periods where antiretroviral treatment was not available. I remember that I used to live with a lot of fear and that I didn't have access to treatment. So thanks to this support, I only received different legal documents. At that time, I was also pregnant. And I can keep on speaking about this. The biggest challenge today is that this topic is not solved at a system level. There are several other projects and different initiatives, but a comprehensive solution within the self-help system for the people living with HIV, we don't have that. So the tendency is to move forward with regards of mental health issues. It is also important to consider those features from different groups. So I am so pleased that today we will speak about those issues related with mental health with regards of the perspectives of all the parties involved, as well as different communities. So we will be able to see how we can integrate and how can we create also these liaisons or these bridges within HIV and mental health. So now it is an honor for me to give the floor to one of the representatives from the scientific community, Mr. Igor. From different communities. So we will see how we can integrate and how we can create also these bridges with regards of HIV and mental health matters. So now it is an honor for me to introduce you and to give the floor to one of the representatives of the scientific society. His name is Igor. He's a doctor as well as a director of the Alliance on Mental Health Preservation, as well as on the Center of these Modern Technologies Sciences. Igor, you have the floor now. Good morning. I would like to thank you for inviting me on participating in this event, in this serious event at an international level. For me, as a physician that on a regular basis I speak in front of some other doctors, this is a new experience for me. So I would like to know what's going on with my presentation. Can we see it? So it's easier for us to follow the information. Okay, so I'm one of the first speakers, and I would like to mention about the mental health aspects and the HIV diagnosis in a more clinical way. This is the doctor's perspective. And I would also like to mention those aspects and factors that help and the type of support that we can provide. That some of them are known as psychotherapy, as well as the self-support elements that can be used by people living with HIV. I cannot move on the presentation. Okay, so this is the slide that shows us the frequency of those disorders of the nervous system with people living with HIV. In the first column, we can see patients living with HIV, and the second column represents
распространены в общей популяции. Собственно, здесь представлены
figures with patients living with HIV and in comparison with the evolution in general. You can see here the figures of these different researchers carried out by different researchers and in different countries, from Norway and many more. So this is of great concern, as Svetlana has already mentioned, because it is true that mental health of people living with HIV, of course, needs a special control. We're speaking about that, and then I'm also running a scientific research that it is related with the mental health of pregnant women and living with HIV. As Svetlana already mentioned, mental health of those differentiated groups shows different figures related with mental health, teenagers, women, and right now you can see here the pregnant women. At least these researches have been held in Russia with 2 interventions, and we have been able to have a specific understanding. Unfortunately, well, this is what's going on at a science level, and it's not translated into the practice.
Please, next slide.
Of course, we need to develop a stronger effort as a physicians and as specialists. Some specialists are very relevant within mental health issues also, and they speak about these mental health disorders with people living with HIV. And this can include any type of reaction. Professor Kortikov mentions that this broad range of different disorders, it's a psychiatric encyclopedia. Not always all disorders are related with HIV, with the virus. And later I will deepen this aspect. Any disorder in any given way is present. So if we want to give a diagnosis, we're speaking about that these disorders that are related with mental health in most of the cases. If we see also the frequency of these mental health disorders, we can find different figures that vary from 38% up to 90%. And with that, I want to say that that's the level of symptoms not necessarily always need the support of a psychotherapist or a therapist. Many times, individuals or people can deal with their own symptoms by themselves. There's also some other figures that say that for those who are imprisoned in a mental health disorder, they almost reach nearly 100%. Next slide.
Можно переключиться? Thank you. В целом, если говорить о психических расстройствах, то это очень сложный
In general, if we are speaking about mental health disorders, we can say that this is a very social, a very complex social phenomenon. And I want to mention psychosocial, because here you can see three elements: bio, social, and psycho. So in that sense, we can say that each one of them, each one of these components, have their own influence for the mental health of the individual. We're not speaking about specifically for those living with HIV, but we are speaking here in general. But if we refer to those who live with HIV, then in this case, we can say that these three elements or these three parameters have their own influence. The bio aspect is the presence of the virus within the organisms. Psycho is the reaction towards this situation, towards the situation of the diagnosis. And then the social aspect is the environment, let's say the society with regards to the mental health of the individual. So that's why we include these three components: biopsychosocial components for those living with HIV. As mental health disorders have an influence in a negative way for HIV treatment as well as for the psychiatric treatments, we as physicians and specialists and psychiatrists, despite the use of the treatment, we need to speak about how they feel about that situation that they are facing. We also need to know exactly at a certain degree how mental health affects the immune system, because sometimes we have found that within the researchers carried out by these psychiatric disorders affect in a very negative way the immune system. So we have this great influence within the organism. So we need to consider that. We need to see the level of influence, and we need to understand what can we do in order to help and support the individual. Next slide, please.
Next slide.
Вот здесь как раз-таки обозначен круг трех основных
So here we can see this diagram that includes three components or three general directions, and these are the different development aspects of the and mental, psychosocial mental. The first one, or the first component refers to psychic, exogenous, organic disorders. That is to say, how the virus influences the nervous system. We know exactly that the virus impacts, that is to say, where the virus attacks the tissues. The second type of disorders are those that are related with the psychoexogenous or neurotic disorders. Regularly, these disorders are related with the fact of knowing the diagnosis, and that is to say that the person has given his or her diagnosis. This is the reaction that they face towards the disease. And as I was mentioning before, this is the acceptance of this diagnosis, which sometimes it's very difficult. In that sense, we need to give our best effort to support them and to help them. I would also like to highlight here that despite the fact that there are many psychologists that work together within these HIV centers, unfortunately, me as a person, and that because of my profession, I'm always in contact with these psychiatrists and these psychologists and these centers. I understand that not in all the centers they comply with their functions. And secondly, is this fear that goes with the specialist. So we also need to work with those problems. So despite I'm a psychiatrist, I understand those issues, and I always say that the psychologist is the first step. They they shouldn't go directly with the psychiatrist, but first with the psychologist. Now we have like more openness towards psychologists. People accept more, and they agree to go first with the psychologist. And the third component is related with the behavior and conduct issues. And this is a result of the first two aspects. Some of the behavior disorders could be that this can remain during the existence of the whole life of the person, that they can have it from the beginning, and then it can get worse. With regards of the HIV diagnosis, in some cases, they might need to have the pharmaceutical treatment.
Итак, я хотел бы сейчас кратко пройтись по основным направлениям.
Now I would like to briefly mention the basic concepts of those disorders that are related with HIV infection. The first disorder, of course, is depression. Here I'm just mentioning some important aspects. Depression with regards of HIV infection. This depression has an impact on the development of the disease. And in this case, let's say that all those disorders related with HIV gets complicated, and also the risk that the HIV diagnosis may scale up into AIDS, it's twice higher. They are telling me that I can move the slides, but it seems that I can't.
Next slide, next.
Next slide.
Ряд состояний, поскольку осталось немножко времени. Next slide, please.
So I want to keep on, and now I will speak about these anxiety disorders. This can be considered the number 2 as for the top disorders, as of the top health disorders for people living with HIV. In a regular sense, anxiety goes together with depression, and we also have this concept that it's called the panic disorder, and nearly 32% of people who live with HIV also has this panic disorder.
And next.
Next slide, please. Next, one more.
Кратко остановлюсь на шизофрении и биполярном аффективном расстройстве. Значит, здесь вот как
I would like to stop here in this schizophrenic disorder as well as bipolar disorder. It seems that there was not a connection between HIV and these two disorders, but in the last researchers that we have held here in Russia had shown that patients with schizophrenia and those who also live with HIV are not taking antiretroviral treatment. That is to say that their viral load is really high. For those stages that are developed at the end with people living with schizophrenia, let's say that the speed of the development of those status are lower. That is to say that there's a positive dynamics in this case. And this is a very interesting data with regards of the treatment for patients with schizophrenia. As you know, there is not a specific medication that might help them in 100%.
Я хотел бы показать слайд с приложениями, которые можно использовать для...
Now I would like to show you this slide with those applications that patients can use for their own self-support. This will be my final slide. Next one, please. Next. Next slide. Next.
Oh, thank you. Я хотел бы обратить внимание, меня просили организаторы, на то, как мы можем сами себе помочь.
Organizers asked me to speak about a little bit on how can we help, how can we have this self-support. I won't speak about these self-support groups. The other speakers will speak about that, but on our side, we have developed these two applications. These are called anti-panic and anti-depression applications. These are two applications that can be downloaded freely, and these are used for those who suffered depression and panic attacks. With the support of these applications, people can get to know a little bit more about their own disorders, either depression or anxiety disorder or panic disorder. We also include several techniques that allow them to mediate with this status, as well as giving some advices. These applications are useful before going to see the doctor or before getting the treatment from the physician. Sorry if I'm running out of time, but well, I would like to show you that there is the possibility to have this self-support, and this is available for anybody who has a smartphone. So thank you very much. Thank you, Doctor. This is a great introduction as for the medical aspects as well as on these applications. I understand that you have to leave the session. No, I still have more time, so in case there are some questions, I will be here. Thank you very much. So now let me introduce you to the next speaker. Her name is Marian Said. She belongs to the European and AIDS treatment group, and she will speak about a project that has been developed currently with mental health for people living with HIV. She will speak about the mental health well-being and HIV project. Marianne will speak about this project, and she will mention the agenda for this area.
Yeah, I think I'm there. Good
Marianne,
afternoon,
you have the floor.
I will present to you today results from a systematic mapping review, which is, please next slide. Yes, there. Which is from a project called Mental Health, Wellbeing and HIV Project. The project aims at exploring the existing knowledge about the interplay of mental health, well-being, and HIV, and translate it into practical recommendations for both community organizations and healthcare professionals in the European context. This recommendation will advise on how to develop supportive and integrated framework within the HIV care setting, which provides people living with HIV with access to prevention, screening, treatment, and care for mental health problems. The framework will take into consideration the specific needs of vulnerable population and address the issues of substance use as well. A European network bringing together the different stakeholders in the field of mental health and HIV is formed, and a platform for them to interact will be established. The expected specific outcomes of the project are awareness, first and foremost, on the interplay of mental health, well-being, and HIV among community organizations, healthcare professionals, and other stakeholders in the HIV field at the European level. And then people living with HIV, to make sure that people living with HIV are empowered to take informed decisions about their lifestyle through a media campaign about mental health, well-being, and HIV. And European stakeholders from community, healthcare sector, policy, industry, and research, and international organizations are considering the interplay of mental health, well-being, and HIV in their respective areas of work based on the findings and recommendations of the project. This is just the aim of the project. Next slide. So now I will just present to you the results of the systematic mapping review. Next slide. The objective of the systematic mapping review was to on the effectiveness of HIV prevention, treatment, outcomes care, and quality of life for people living with HIV, and identify the correlation between mental health, well-being, and long-term treatment. Next slide. We found a total of 35 studies from the European context. There were a lot of other studies, mainly from the USA and from Africa and Asia. We found 35 studies that met our inclusion criteria. 51% of the studies were from Northern Europe and mainly from the United Kingdom, were 11 studies, and then there were 4 from France, 4 from Russia, from Netherlands, from Denmark, from Spain, Ukraine, Kazakhstan, Romania, Switzerland, Poland, Sweden, and multi-country studies. 2 were multi-country studies. Studies were from 2009, published between 2009 and 2020. Next slide, please. The study population, 32 of the studies focused on adults and 3 studies focused on adolescents. We found no studies focusing on older adults, or there were more men than women included in majority of the studies as usual. Only 1 study had more women than men, and this was from Russia. 1 study compared quality of life of untreated HIV controllers with quality of life of treated HIV controllers. This HIV patients, sorry. This was the only study. Study design, all studies used quantitative methods, with over 50 of the included studies being cross-sectional study with or without control groups. 7 studies included a control group. Next slide. The studies were mainly looking into different problems. They were not looking at the same kind of problem. 10 studies reported on the prevalence and predictors of psychiatric symptoms, and 1 study on psychosocial and mental health characteristics. Other studies reported on influence of psychiatric distress on drug resistance, on adherence, on treatment initiation, and treatment adherence and interruption. There were 5 studies that looked into psychological factors associated with health-related quality of life in adults, and 1 in health-related quality of life in teenagers. 1 study examined the prevalence and risk of schizophrenia in people living with HIV. 1 study compared mortality among people living with HIV and with serious mental issues versus those with only serious mental issues. One study from France examined sleep disturbance, 1 examined self-harm, and 1 examined neurocognitive impairment in people living with HIV. Next slide, please. Main findings. The body of research points to high level of psychiatric morbidity among adults and teenagers living with HIV in Europe, as well as other parts of the world. People living with HIV tend to have more mental health problems than non-HIV infected individuals. Next slide. I will just briefly mention the mental health dimensions that we identified in the studies. Depression was among the mental health problem found in people living with HIV, and it appeared to be the most common. Several studies reported an increase in depression symptomatology experienced by people living with HIV. This was not only the case in Europe, but also in other continents, for example, Africa, Asia, and America. Next slide. There were a few studies that reported on direct effects of depression, and 1 study from Kazakhstan reported on depression and the immune system. The study was investigating the occurrence of depressive symptoms and the relationship between HIV treatment initiation and ART adherence in people living with HIV in Kazakhstan. A relationship between depression symptoms and lower CD4 was evident. 7.1% had a CD4 lower than 350, while 0.9% had a CD4 higher than 350. Next slide. Depression and sleep quality. In 1 cross-sectional study conducted in France, poor sleep quality was observed in 47% of study participants. Factors associated with sleep disturbance were, among others, depression, being male, living single, and being in active employment. These were just a few among other factors.
Marianne, sorry,
Yeah?
can I ask you to read slowly, please?
Yeah, no worries. Depression and mortality. There were no European studies found, but there were studies from other continents that looked into depression and mortality. And the other mental health issue that we identified was anxiety. People living with HIV showed higher levels of anxiety. This pattern was also found in teenagers, not only adults. There were 3 studies, 2 from Ukraine and 1 from Russia, that reported on anxiety. 1 that looked into social factors and their association with anxiety among perinatally and behaviorally HIV-infected young people in Kiev and Odessa. This study found that there was moderate to severe anxiety symptoms, and these symptoms were associated with lower self-esteem, less stable living situation, and history of drug use. There was no difference between the mode of infection, but there was high occurrence of anxiety in both groups. And then another study from Ukraine that looked into HIV, people living with HIV with injecting drug use in Ukraine, found that this group had high anxiety scores. And then finally, in a Russian study, high level of anxiety-related symptoms were reported, where 51.3% of 492 people living with HIV in St. Petersburg scored above 43 on the anxiety score, the STAI anxiety score, And this percentage is comparable to patients with psychiatric. This score, the 43 score, is comparable to medical patients with psychiatric components to their health problems. While 37% of these participants in the study scored above 48, and this score is comparable to those found among psychiatric inpatients. So this shows that the level was the degree was quite high when it comes to the prevalence of anxiety. And then another mental health issue identified was post-traumatic stress disorder, even though it was only one study reporting on post-traumatic stress disorder. This is a French study evaluating the association between post-traumatic stress disorder and voluntary treatment interruption. This study showed that patients followed in a French hospital, 13.3% were diagnosed with PTSD and still had symptoms a month later. The same group of patients had a history of a suicidal attempt and were more likely to be diagnosed with HIV in the previous 12 months. Next slide. And another issue was self-harm. And this is one study of young people in the UK that identified the prevalence and predictors of self-harm in 303 young people with perinatally acquired HIV and 100 HIV negative young people with sibling or mother living with HIV. A total of 13.9 reported having ever self-harmed, but there was no difference between HIV status. So here it was nothing. It didn't have anything to do with being HIV positive or not. So those are the mental health issues that we identified so far. And then next slide. Quality of life and mental health. There were a couple of studies, like I said in the beginning, that looked into quality of life and reported on mental health variable associated with quality of life in people living with HIV. And one study is from Kazakhstan, which showed that major depressive disorders was an independent predictor of poor health-related quality of life. Another Spanish study revealed that a distressed mood as a factor with greatest influence upon mental health and quality of life. And one other study from Sweden, which revealed that in 1 of 4 respondents experienced moderate to severe hopelessness, negative self-image, and hopelessness was a predictor of low quality of life. Next slide. There was another study also comparing the quality of life of untreated HIV controllers versus quality of life of treated HIV patients in a French national survey. And this study found that the quality of life scores in terms of health concerns and mental distress was significantly lower in HIV controllers than in non-HIV controllers. And lastly, one study from Spain it showed that the average mental quality of life scores were higher among women than men. This is maybe one of the few that looked into gender differences in mental quality of life or the mental health of people living with HIV. Next slide. Other correlates of mental health outcomes and quality of life. In Stoke-on-Trent in England, it was observed that those with white ethnicity were a higher risk of mental health conditions compared to Black Asians and minority ethnic groups. Women were also at high risk of having mental health condition. People who use recreational drugs was also a significant factor. This was one of the only studies that looked into those demographics. But there was another one in Denmark that identified that symptoms of depression were more pronounced in women and individuals who identified themselves as being ethnicities other than Caucasians. So there was a difference between the UK and Denmark when it comes to ethnicities. And one study in Russia reported that injecting drug users and MSM injecting drug users had significantly greater depression than heterosexual non-injecting drug users living with HIV. So one of our objectives was to look into mental health outcomes when it comes to HIV prevention, HIV care, and treatment outcomes. Mental health outcomes when it comes to HIV prevention, mental health illness and risk for HIV acquisition. Only one study looked into this, a Danish study investigating the risk of HIV after diagnosis of schizophrenia. This study found that schizophrenia was not associated with an increased risk of HIV in individuals without substance misuse disorder. So people with substance misuse disorder are a group that needs to be taken into consideration when it comes to mental health issues. And this there was no much reported on HIV prevention in Europe, but there were a number of studies from the US. And in the USA, mental illness contributes to 4 to 10 times higher increase for risk of HIV acquisition. For example, one study reported that HIV prevalence in the US population with serious mental illness was 2% to 6%, while prevalence in the US general population was 0.5%.
Sorry, Marianne, you have 1 minute only.
Okay, yeah. So I will just quickly go through, if you just scroll to the last slide, not last, but gaps which we identified so far. Yeah, there. We identified that there were no studies that reported on problems with activities of daily living. There were no studies that reported on suicidality of people with serious mental issues living with HIV. And then no studies that reported on psychosocial factors. That looked into psychosocial factors like disparities in socioeconomic status, like housing status, and their contribution to mental health outcomes. There were no studies that looked into HIV-infected detainees and mental health outcomes and other socio-demographic factors, and intersecting stigmas like sexual minorities, sex work, substance abuse. And we found no studies that directly examine the correlation between mental health well-being and long-term treatment. It was only one study, and this reported on women with longer period of HIV diagnosis presented with lower levels of mental and physical quality of life. Yes, thank you.
Thank you so much. Спасибо большое, Мариам. Спасибо большое, Егор, за ваши...
Thank you very much, Marianne. Thank you very much, Marianne, for this great description on these clinical aspects and different researches carried out. We're always speaking on the fact that it is important to promote the diagnosis and also to find those resources so we can offer those services that are related with mental health. And in that sense, we need data, we need figures, and we need that level of evidence. So thank you so much for your great presentations. And I think this is useful as a basis for those who want to promote those problems of mental health within the topic of those scientific researchers. Now, it is an honor to give the floor to Anastasia Petrova. She is director of an organization in Russia, and Anastasia will speak about a very important aspect on how on the great influence that COVID has for people living with HIV and their mental health. So, Anastasia, you have the floor. Thank you. We're trying to see how can I see my presentation. Give me just 1 second.
Rachel, do you have my presentation? Sorry.
Hi, Anastasia. This is Niluka. Okay, yeah. Rachel will be sharing your presentation.
Yes, this is it. Yeah, and the next slide, please. Здравствуйте еще раз. Меня зовут Анастасия Петрова. Я из России.
Good morning again. Good evening. I'm Anastasia Petrova from Russia. I'm the director of the Russian organization Peer Partners NGO, and I'm an activist and a psychologist as well. As it has been mentioned, I would like to speak about the connection between this liaison that exists between COVID-19 and HIV. This is very significant because tomorrow it's the International Mental Health Day and it's organized on October 10th. So today we're celebrating in advance. The topic of this year is mental health for everybody. So this year it has shown that mental health, as with regards of all these aspects, are related with all around the world, and as for the care that has to be considered for mental health is really important. So, and mainly this year because of this COVID-19 epidemic, now it's been evident. So organizers asked me to speak about mental health issues within this COVID-19 disease. And this is also a topic of my own personal interest. Next slide, please. So let me speak a little bit about our organization. We support within the communities of different patients. We are a platform that provides different resources for development of the communities, for their own growth. So all the things that we do is the result of this inspiration that was forged through different years of work with people living with HIV. So for me, they represent a great example of the many possibilities of the communities. Even this conference is a result. This is a great example of the great effort carried out by the communities, of all the resources that they have in order to change their lifestyles, as well as on changing the opinions of society in general. Now I would like to highlight the fact that people living with HIV are used to work together, and they are used also to help themselves as for prevention issues, treatment, HIV, access to treatment. And now, as part of my presentation, I would like to keep on creating these mental health services for the whole community with those same resources and with that same peer approach that we all know, so we can include it in this HIV area. Next slide, please. Next slide.
Thank you.
Previous slide, please.
Okay. Конечно, да, всем очевидно, что 2020 год – это год вызова.
It is evident for everybody that this 2020 year represents a year of many challenges. So the challenges for the health system of different countries and almost all the countries in the world represent an economic challenge as well as a challenge for mental health issues for the global community and individually also. Today, we have several researchers that show the connection between COVID-19 and the mental health of all the world. And this is also related with different factors. For instance, with the fact that coronavirus represents a new threat and unexpected threat, as well as a threat to our life. And this situation itself creates a lot of stress as well as great depression levels. Of course, the general situation makes us think that it is possible to get worse with regards of the mental health of many people. Isolation itself as a prevention measure of this disease has been an important factor that also has worsening the mental health of many people. We have figures that those who live with HIV had shown and that are more vulnerable to this disease. Access to services that are related with HIV or those that are related with mental health had also been worsened a lot. Nowadays, we have just a few researchers. I have found two of them, and I will try to speak about them a little bit. Next slide, please.
Next slide, please. Thank you. Итак, первое исследование было проведено в
Thank you. The first research was held in the US, and it covers different factors, not only mental health issues, but also the economic status between men who have sex with men. This was a broad research, and the average of these participants who respond to this survey showed a very high outcome, as you can see in this slide. It was detected that depression was in a 35% between MSM during this disease. 34% show that they have a high level of anxiety. In comparison, the average indicator of depression between the general population is 20%. So here you can see the high tendency. Next slide, please.
Next slide, please. Thank you.
Thank you. Another study carried out was the study developed on the impact on mental health and quality of life between young people during this COVID disease. More than 70% reported that they felt anxious as for this COVID disease. Next slide, please.
Next slide, please. Thank you.
Thank you. What were the reasons of this anxiety? Of course, the first one is related with the concern of their own health. The second indicator was the concern about their family members, their closest ones. And also the next one is those problems that are related with the HIV infection. Practically half of the participants of this survey had shown that their anxiety was related with those problems faced as for access to treatment and access to medications. Next slide, please.
Next slide, please.
Next. Next slide.
Еще молодые люди с ВИЧ говорили о тревоге по поводу изоляции и тревоге, связанной с...
Here we would like to mention also this anxiety related with isolation and stigma with regards of their HIV status. Also, gender and sexual violence. Many people had faced serious problems due to their life conditions.
Next slide, please.
These life conditions didn't allow to have this participation or this well-being. As for access to services, it has been a little bit difficult. Also, here we're speaking about mental health services. So we can see that 34% had experienced these difficulties with regards of access to medication, specifically to psychiatric medications. 9% hasn't received this pharmacological medication. And in the second part, you can see that 40% of those participants did not receive access to the psychological support. 40% reported that they hadn't asked for it. Next slide, please. The outcomes of that survey show that 50% of young people between 18 to 29 years that live with HIV mentioned that during these COVID-19 epidemics, 50% said that they needed support for their anxiety, depression, as well as other conditions. And 23% mentioned that they needed this peer support with relation of their HIV status. Next slide, please. Next slide, please. This slide is related with the response, how communities can support and can respond to those challenges faced by this disease. What are the things that we can do? What can we do in order to improve quality of life as well as mental health issues for those people living with HIV, having this support from the communities? In that sense, we have developed an HIV model. This model includes 5 steps, so we can have this peer support for people living with HIV. The first step is called as listening. This is a possibility that helps people in order that giving them these spaces for them to be heard. This is the first step to support, to provide this primary psychological support. Next slide. Next slide.
В 2017 году темой Дня психического здоровья была депрессия.
In 2017, the International Day on Mental Health was depression, and the World Health Organization developed this call, Let's Talk, Let's Speak, because this is the first step in order to move away from this inner isolation. This is the first step so people can share their own concerns, and it is really important for this peer support within the supporting groups. They have to include this type of help because the closest person or the peer can help you to open so you can share your depressive concerns. Next slide, please. Step 2. Step 2 is get informed. In this sense, of course, there are several ways to be informed with regards of the symptoms of depression and anxiety. Next slide, please. I am not going to mention all the steps and all the symptoms, but it is important to remember that if any person shows any type of problem or any sleep disorders or this blame feeling or having this self-esteem problem, we can say that they are symptoms of depression. So in that sense, it is important to tell the people or to tell this person to experience fully their own feelings. Next slide, please.
Next slide. И здесь очень интересная инфографика, которая помогает нам определить, где тревога.
This is a very interesting infographics that allows us to detect the differences between anxiety and COVID-19. This is also important to be informed because the main concern or the strongest concern within this COVID disease has been anxiety. It's important to recognize anxiety symptoms as peer counselors. It is important for us to understand and to know these symptoms so we can help them and we can support them. So what is the next step? To do this scanning. And that is to say that we need to go to the physician. Only the doctor can give us a diagnosis. But before that, before going to see the doctor, we can detect those symptoms. We can do that by ourselves. There are several surveys that are related with depression and anxiety that you can use. You can answer those surveys. They are available online or physically. And in that sense, we can have this self-diagnosis before attending and before going to see the doctor. Next slide.
And next.
Next. Next slide, please. So, well, the next step will be to support, to help. It is important to remark that depression needs medical assistance, medical support. I am not saying that we can replace this peer support with the medical support and the other way around. If we have this suspicion that a person is falling into depression, it is our responsibility to send that person to the specialists. As for depression or anxiety, the approach that has been well recommended is this behavioral therapy. And there are some other steps that we can implement, but the others may need the assistance of the medical staff. Next slide, please.
Настя, 1 минута, пожалуйста.
Хорошо. Так, например, Всемирная организация здравоохранения рекомендует такой подход, как...
The World Health Organization recommends to use this interpersonal therapy approach. Let's say that this is like the first line treatment for depression, and it is very easy to find information in different languages. And this approach can be work in groups with a support of a carer. There's no need of having a professional. It is enough to have just a counselor or a peer counselor or a person that is well prepared in order to run these group therapy sessions. Next slide, please. And of course, the last step is the invitation to be empowered as a community. Here we're speaking about those peer support groups. When a person is experiencing this depression or when they are just moving out from depression, it is important to have a self-support group with regards of these mental health issues. Groups can be created not only for people living with HIV, but also with topics such as mental health. I would invite to create specific groups for mental health support, because it is not always possible for those groups of HIV. Sometimes it is not easy for them to speak about their mental health disorders. Next slide. This is the most important manual. It is easy to find and easy to use. Next slide. Recently, our organization just published this support manual for those people living with depression or with this bipolar disorder. This guideline is available in Russian and it's free, and that allows you to create this health support group from scratch. Next slide, please. Thank you for your attention. I hope I inspired you to develop these mental health disorders services for the whole communities. Thank you, Anastasia, for your detailed presentation, for this great perspective. And also, these tools are really relevant and important. It is also important to know how and when to ask for this support and help. It is also important that you mention this peer support, because within this context, it is important to understand that those people living with HIV, it's not a homogeneous group, because there are different individuals, different people with different vulnerabilities, as well as different identities. And right now, I'm going to give the floor to Dr. Tadesh, who will share the experience of a group from MSM and the peer support within the harm reduction framework. So this is a research of MSM and men who use drugs. Dr. Thomas, I give you the floor. Es un honor y un privilegio estar aquí con ustedes.
For the community and also for the services that are out there or could or should be out there. By way of introduction, some of you may already know me. I'm originally from Budapest, Hungary, but I've been living in Berlin, Germany for a couple of years now. By profession, I'm a linguist, a psychologist, and I have a PhD in social psychology. And as I'm not a doctor, I'm a doctor, but a different kind of doctor, so not a medical doctor. I also live with HIV, have been living with HIV for 17 years. I'm a former substance user and I'm a gay man. So I'm very much in the middle, in the intersections, and there were several mentions of the intersectional approach today. I'm very much in the intersections of these various, if you like, vulnerabilities, even though admittedly my life has been one of privilege. I think maybe I can control the slides. No, I can't. So can we please go to the next slide? Thank you. These are my disclosures, not a lot to disclose. So I think we can move on. I don't receive funding for my research. And if I do receive honoraria, then these are donated to my home organization, the European Patients Academy. Next slide, please. So this is what I plan to talk about very quickly today. One is the prevalence of mental health issues in the MSM, men having sex with men, but also, or differently put, maybe in the, or easily said, in the gay community. But of course, men having sex with men are not just gay people. Also, something that's been mentioned by several speakers, actually all the speakers so far, which is the root cause that we find is depression. And in this context, I will also highlight the importance of shame and how we have to talk about shame. And this is why the Berlin psychiatrist and peer helper Jan Grosser is quoted here. Also, I will point to the importance of a holistic approach in providing these type of services to men having sex with men who are also using drugs. The importance of screening, and I will give a bit of background about how screening can be done in a community setting as well. And I will also talk a little bit about interventions such as therapy, also peer help, of course, and some systemic changes that can contribute to making sure that the right services are available to the people at the right time. And the reason why I quote Professor Rimian here on this slide is because he had a groundbreaking presentation at the CROI conference, the conference on retroviruses and opportunistic infections in 2018, which was a plenary presentation. And the importance of this presentation was that actually it was the first time that someone spoke about the interconnectedness of mental health issues, social collaterals, the social environment of the individual, and HIV, and also substance use. So while this has always been sort of on the agenda of the community, we've always known that there's some connection there. This holistic perspective, this unifying view, was missing before. It was only 2 years ago that Professor Rimian, who's a psychiatrist himself, took a deep breath and combined all these different insights and perspectives into an overarching approach, of which I will give you some quotes. Next slide, please. I think that this has been picked up by several speakers before, and I think that what we heard from Marianne was particularly interesting and relevant, and I'm endlessly thankful to the European AIDS Treatment Group that they are pursuing this project, which was, by the way, started a couple of years back when we first started talking about mental health issues within the EATG. Now, we simply know that the prevalence of mental health issues is significantly higher in HIV positive populations than with people or with populations that are not affected with HIV, that don't live with HIV. And I will really not want to go into much detail with this particular slide because you've heard the hard evidence, the science behind it from Marianne, but also from Yegor and Svetlana. Or Anastasia rather, sorry. But I think it's important to see that while we cannot really tease apart cause and effect, there are some arguments that say that people who suffer from depression are more prone to get into situations where they more easily contract HIV. And also we know that once you contract HIV, you're prone to suffer from depression, which is one of the consequences of the virus. So the infection itself and the chronic inflammation that's happening in the body. It is also attributable to some treatment modalities. So certain HIV medicine can cause or worsen depression, but that's really not the issue here. What is the cause and what is the effect? What is important for us in this case is what we can do about it. And given that the healthcare systems are so overburdened, especially with the pandemic that was mentioned just a couple of it's countries like Germany. healthcare systems are crumbling and are suffering under the pressure that's on them. And I will not even go into the causes of this pressure because there are many. But it's simply a must under these circumstances that the community tries to take over the community of people living with HIV and the communities of people affected by HIV and by substance use, that they take over, they assume some of these services and try to help as much as possible also in places and settings where the healthcare systems are maybe no longer able to provide this type of service. Now, I work as an educator with the European Patients Academy, which is a pan-European endeavor, teaching patients, teaching them to become patient experts in their own disease areas, not just HIV, but all sorts of other diseases. And we can see in this daily work there how empowering education, knowledge, and meaningful activity can be. And so we argue that if you channel that energy into providing harm reduction services, into providing counseling services or psychological support services within the community, that also has the consequence of self-empowerment and of community empowerment. So this is the underlying reason why we argue so strongly for community involvement in this field. Next slide, please. Thank you. Now, again, this is something that has been picked up in several presentations before, and I would like to make a special reference here to Igor, who described a very similar structure, but in maybe with a different approach or perspective. I took this slide from this presentation of Dr. Remian that I referred to in the beginning of my talk. And I wanted to bring this to you and show it to you so that you see what are the various factors that can contribute both to mental disorders, but also to HIV, to the risk of contracting HIV, and also then to living with HIV. Now, there's one, excuse me, one abbreviation here, which is SES, that stands for socioeconomic status, which you may not be familiar with as an abbreviation. However, if we take these 7 categories, like demographics, biological factors, community density, so how safe is your community, how closely supported you are, or vice versa, how much violence is there in your community. So that's what density describes. And if we take also intersecting stigmas, then the psychosocial factors mentioned several times already, environmental factors such as war or violence, natural disasters, and socioeconomic status. So all of these factors can contribute and can worsen both mental disorders and also the chances of contracting HIV, and then the chances of surviving with HIV. So it seems that it's simply impossible by now to take these tease these factors apart. And so it has become quite obvious how closely interrelated these two fields are. Now, this is important for us, and this is relevant for us to understand, because this means that when we do interventions, these interventions cannot remain on the level of biology and medicine. It's not sufficient just to give HIV medicine to a person who lives with HIV, but we also must look at the broader environment of that person. And we must try to understand what it is that affects his or her life and influences these different factors that may worsen his or her status, both his HIV status and also his or her mental status or state of mind. This is, I think this is somehow very obvious if I just repeat what Professor Remian said, that the mind and the body are one. However, so you cannot separate your mind from your body, or your body and your soul. That's not how it works. We are all locked into this physical body, and so we have to take care of both aspects simultaneously. We have to take care of the body, but also we have to take care of the mind and of the psyche of what exists in that mind of the individual. And where can it be done better? Where else can it be done better than in a community that knows you and that is familiar with your issues? Next slide, please. So this is why we argue so strongly for a holistic approach. And in this holistic approach, we have found a minority stress model, which has been well described in the literature several times throughout the last 2 decades, more or less 2 decades. So that we find that the minority stress model is a very helpful tool to come to an understanding of what is going on in this intersection of mental health and HIV. It is ultimately about the acceptance of otherness. It is about the acceptance of being different from what is considered normal or standard or the benchmark. And when I speak about acceptance, it's not just external acceptance, so that your environment or society or the people around you accept you, but also that you have to accept yourself. And this is why it is so important to talk about shame, because over the years in these conversations with people who use drugs and with people who live with HIV, we come back to this as a recurrent theme, as a recurrent topic, that there's a lot of shame in these conversations. Now, shame is not new in psychology. This is something that we psychologists have been working with forever. And it's a very relevant point. However, when it comes to substance use or when it comes to HIV, it is something that's often swept under the carpet, because there might be so many more pressing issues that need to be dealt with that we simply don't get to the level of talking about shame and feelings of guilt because of contracting HIV, feelings of guilt because of substance use, and shame, feeling of guilt and shame because of working as a sex worker. So there's a lot of factors that can contribute to this. But if you approach the problem from this angle, and you say, if you acknowledge that there's probably a lot of shame working in the background, that will help your work as a peer helper and as a community helper as well, because that gives a handle on the problem that you can grab. And if you can ask about this directly and in a targeted way, then it will also bring you closer to a solution or to helping the individual with his or her challenges. Now, let's move on to the next slide, please. Now, this is actually why we also argue that, okay, so if this is the case, if we know so much about this field by now, from research by doctors and from our own experience within the community, then of course we can also do this ourselves. This is not magic, this is not witchcraft. This is something that other people, psychiatrists, psychologists, and practicing peer helpers and counselors have learned. It is knowledge. And so it can be conveyed, it can be taught, but it can also be learned. So it's not, it's not a gift that was given to you from heavens, but it's simply something that you can learn. And if you can learn, then I can learn it as well. So it is, if you could learn it, I can learn it as well. So why not do this then on the community level? It does, of course, pose difficulties for the service provider as well, because you have to do diagnosis in a non-hospital and non-psychiatric setting, which can be challenging at times. Also, you have to pick up uncomfortable topics such as the client's or the person's sex life, substance use habits. This is not something that we are very comfortable.
1 minute, please, Dr. Tamas.
Yes. Also lack of time. And then there's this other issue with overlapping symptoms, stigma and shame, as I have already pointed out. So after all, this is something that can be shifted to the community level. Next slide, please. Okay, so this is what I've just explained. You can do screening for mental health, but with education only, but you can do that on the community level. Let's go on to the next slide. And so this is what we experience, for example, in Berlin on this basis. We have a lot of community solutions, and we find them that we find them to be cornerstones of the services that are provided. But mind you, these are also supported by the local and the federal governments. So we do get financial, but also moral support from the various levels of government. We know that therapy works, so we concentrate on it. And we don't try to explain why it works at this stage, but we just try to exploit that benefit that therapy offers. We know that there are no quick fixes possible. So we have to build on a long-term relationship and progress. And so we try to build these long-term relationships with the clients and create a community around them where they don't have to feel ashamed and where they don't have to feel alone and isolated. And of course, the holistic approach comes back again. But if you go to the next slide, I also have a short explanation of what is going on in Budapest, my original hometown. Where none of this exists. So it's not so easy to say that, okay, this is what you should do, because we understand that there are external conditions that will limit your scope of action, but still you should never give up. This is something that can be done on a grassroots level. And my last slide shows 4 organizations. If you go to the next slide, please, shows 4 organizations that have been doing this very actively in Berlin. And I want to encourage you to reach out to these organizations and ask them for their methodologies, for what they have been doing, why they have been doing that, and what are the results. These organizations are only too happy to share their experience with you in writing or orally and tell you what is it that you can do, even if your resources are constrained, even if you don't have enough money, even if you lack volunteers. There's always something that you can learn from these organizations, because they also started very small at the time when they started. And I will stop here, and I'm happy to receive your questions afterwards.
Спасибо, доктор Тамаш. Очень важная презентация в контексте того, что вы действительно обратили внимание.
Thank you very much, Dr. Thomas, speaking about this context on the relevance and the intention of the environment for those who surround us, and also to know about those collateral factors that surround people living with HIV. Also speaking about human rights and safety. So thank you very much for calling us our attention and for mentioning these violence and prevalence issues. This is also an additional load for the impact of people living with HIV. Now, let's speak about another group, specifically for women living with HIV. And this topic will be presented by Natalia Sidorenko. She represents the network of women who live with AIDS in Eurasia. And I also want to mention the research that I had carried out. These are the figures that had been held with the efforts from the community and with the difference of several years also. But it has shown that the situation faced by women, young women and girls are completely different for those who live with HIV, for women who live with HIV. Let's say that the shame that they experience and the differences, it's between 16% denial, it's also another factor. Self-esteem represents 17 among girls and 49 between women. So I give the floor now to Natalia. Thank you very much. Let's move to the next slide, please. Today, we have spoken a lot about mental health and its relationship with HIV infection. So when I was preparing for this session, it was a discovery for myself because I haven't thought about that before. It happens that a psychiatrist can give consultations with regards of HIV prevention, and that is good. The first presentation spoke about the relationship between these high-risk sexual practices and mental health. In this case, we have several collateral states, such as the use of psychoactive substances, sexual behavior of risk, post-traumatic stress, as a result, violence. All those factors are related. Next slide, please. So when I was preparing for this session, it was not very easy because, well, I live with this bipolar disorder. 4 years ago, I got to know about this disorder, and now I'm in this depression stage. So it has been carried out a research of women. There were 187 women that participated in this survey, and this has surprised me a lot, having these active responses from women. This shows that this topic is more it's nowadays. I mean, this is a very important topic nowadays. Most of the women who participated in this research are from Russia. The average age was 38. 62% say that they had suffered insomnia. 68% had mentioned that they have that their mood has been altered for more than 2 weeks. And an important disorder is 68%. So I'm surprised that it didn't reach the 100%. Next slide, please. We have asked this group of women if they have the possibility to have access to a psychologist or a psychiatrist, and within their clinics or within the AIDS center that they go on a regular basis. 30% say that yes, that both specialists are available for them, and also 52% mention that only psychologists, and 53% that psychiatrists are only available at the centers. And 14% said that they don't have the possibility to have access to both specialists.
Или работает кто-то один, мы спросили, а нужен ли такой специалист. И вот практически 90% ответили, что, конечно, он нужен. Вот.
Those who mentioned that they didn't have access to those services, they said that they have. Next slide, please. We have also asked why psychologist is needed in those centers, and most of them said that it's needed because of counseling services after receiving their diagnosis, on how can they live with this diagnosis, and how can they start the antiretroviral treatment. There was not an option of the case that, let's say that there's a person that wants to speak about their own personal mood and personal situation once that they face this diagnosis. Among those women who said that they have the support from a psychologist or a psychiatrist, only 14% said that they went to these specialists in the last year. And the reasons given were that 33% was depression, 33% fear to die, or the acceptance of treatment, and 33% antiretroviral treatment. Next slide, please. So let's remember that a very high percentage of women responded that through the last year they had suffered insomnia, of low mood behavior. Most of them also said that they didn't have the need to ask for support from a physician or a doctor. Another response that they said is that they faced the difficulties to make an appointment because of the working hours or the location of this specialist. Also, many women said that they were afraid that their own diagnosis was disclosed, so that's why they didn't ask for support or help. Next slide, please. This slide shows the amount of women that had suffered disorders in the last year, and we've asked them to share with us what were the ways that they face this situation. 50 women out of 129 said that they are still suffering, that they leave this situation alone without any support, and in that sense it has been difficult for them. 57 of them ask for support from their relatives. They had taken the antidepressants, and they had taken also psychoactive substances and maybe alcohol. Or they also ask support from a psychotherapist or a private psychiatrist. 20 out of these women outreach these groups for self-support for people living with HIV or any other type of health support groups. It was also important for us to see the level of participation of these self-counselor groups for women living with HIV. Also, some of these women mentioned that they had taken antidepressants or any other medications not prescribed by a doctor. And it is to our surprise this situation, because some of the women, they cannot have access, or they cannot go directly to the doctor. Next slide, please. As I already mentioned, this answer really surprised us a lot. And of course, well, this topic is really important. We need to give attention to this, because most of the women who answered this survey said that the role of the psychologist is to help us accept the diagnosis, or also to get some other support with regards of mental health. And despite the fact that the level of insomnia, concern, and some other disorders among women is really high, women don't ask for support from these specialists in a frequently way. On a regular basis, they prefer to ask for help and support from their relatives, or just leave their experiences alone. So I hope that this survey helps us changing the situation and being able to integrate more services. Thank you very much, Natasha, for your brief presentation. Thank you for helping us on Saving Time. And also thank you for giving us this perspective from the community that really shows what are the gaps that prevail and that also need our support. Unfortunately, we're running out of time to have this discussion. We have less than 15 minutes. So as a moderator, I would like to ask Dr. Tamus and Marianne, you work at a Europe level. So this question is related with the fact that we know that throughout the history of the development of the disease is completely different in Eastern Europe and in Western Europe. So what do you think about that? Is there any correlation or is there any differences between the access to services for mental health issues and treatment for those disorders of mental health issues? Is there a difference between Eastern Europe and Western Europe in that sense for accessing these services for mental health issues?
There's a huge difference.
Hay una gran diferencia.
If I start with my, if I may start with my response, it's I don't even know where to begin and how we can bring these two domains closer together. There has been a tremendous difference, and what I find is a big threat or a risk, if you like, is when we try to adapt West European models one-in-one, like a one-size-fits-all solution to Eastern Europe, which will happen. The historical context, the philosophies of these countries in the East versus the countries in the West are completely different, sociologically speaking, historically speaking. So I mean, recognizing the underlying science, so that psychology and sociology and medicine are pretty much the same for everyone. So starting from there, I think that the superstructures of care must be constructed completely differently in different regions of the world. So not just in the East and West of Europe, but also if you go to Africa or if you go to Central Asia or further beyond, we cannot use the same models. So oftentimes we make this mistake that, okay, this has worked in the UK, then let's adopt this here in Russia or in Ukraine, but that doesn't work and it's bound to fail. So I think we have to do our own homeworks in our own settings and try to understand and describe what's going on in our own countries and regions and act accordingly rather than to transpose solutions from one place to the other. Marianne, I don't know how you see this.
The question was in Russian, so I didn't understand anything.
Yes, the questions was.
The question is
between Eastern and Western Europe in regard to HIV and mental health.
Yes, I do, and I think that was also evident in the review that we did. I think people experience challenges differently, and then there is the socioeconomic factors as well, and healthcare systems. So it might be that in different places things are caught differently. So I think that generalizing will be wrong, but that these issues should be looked upon from where people are coming from diverse group, from diverse populations.
Thank you. Следующий вопрос я хотела бы Анастасии адресовать и Егору, если он еще с нами.
The next question is for Anastasia and Igor, if they are still connected. Can you give us your opinion on how can we organize this coordination? Who can have this leading role, and who should coordinate this relation? Let's say, if the HIV centers or the psychological and mental health services. How can we find this intersectionality, and how can we achieve an integration? Thank you for this question. I think that nowadays in this region of Eastern Europe and Central Asia, we see that support psychological and psychiatric services are not feasible. They are not integrated within the healthcare system. As Natasha was mentioning, those psychologists that are working in these HIV clinic or centers are not interested in the mood and in the status of the individuals. They have certain activities and there are certain tasks that are imposed by the institutions, that is to say the follow-up of the treatment and many other topics, and they are not devoted to offer a quality service. As for the mood and the psychological status of the people, and from my personal perspective, as I've seen and as the history has shown us with regards of the topic of HIV and access to treatment, fortunately or unfortunately, these treatments are based on the efforts from the community, and in this case, the global community. The states needed to change their focus, and they needed to change in order to preserve the health of their citizens. So if we are speaking about mental health, the perspectives of the communities, of these root communities, are useful and will help us more. The practice in our region demonstrates that the societies and the communities of peoples who live with these psychiatric disorders and problems are coming together, and their voices are being heard more frequently. That allows us to have a dialogue with the physicians and with doctors. Hopefully, let's pray that in the near future we can have this dialogue with the governments at the state and the national level, so they can include those topics of mental health, because that's a possibility and that's a need of all the communities. Thank you very much. That's true. It's truly inspiring also. If we were able to achieve this coordination role for those who are really interested in offering these services, and I speak about the patients and people living with HIV. I would like to ask now a question to Natasha. She gives technical support and she belongs also to the community. She works directly with women living with HIV. So let's dream a little bit, Natasha. Let's assume that tomorrow you have all the necessary resources available for you. What would you do if I tell you, Natasha, you have all the resources available to provide these services for people living with HIV, and specifically for women who live with HIV? Who will be your experts? How will you design those services for supporting the mental health of women living with HIV? Of course, this is a very difficult question. I think that we should put together these two communities. We need to join these communities. I've seen how different groups have been developed, and the self-support groups for people living with bipolar disorders in Russia. I see how these resources have been given for attending post-delivery stress. And I think that we shouldn't give all these tools to the specialists. We also need to empower women. The solution sometimes it's very simple, and many times depression is not treated as a real disorder. And this is a topic that creates a lot of stigma. And sometimes I've been asked, why do you speak about that? People do not want to know about that. And this is what I face. And when I develop my sessions and my workshops, I see that many women, they haven't even done a simple testing on trying to understand if they are depressed or not. So this is my recommendation, just to go and visit a doctor. And then there's a question, where they should go? We have those specialists that can help us to see this problem from a multidisciplinary and complex approach. And we can also mention the topic of this, the use of psychoactive substances. Some psychiatrists are willing to see women as an object and
и помочь ей найти подходящее для нее лечение. Вот. Мне
and as
кажется,
a subject, and in that case, we need to see women as a participant, as an individual of this, as a participant of this process that has her own voice and that has the power of make their own decisions with regards of their life. So the situation that we are facing nowadays, it is not very happy for me. I know, for instance, that the organization from Anastasia has helped us on putting together these friendly experts in a regional level. So we might join them and we can ask them what are the needs that they have. Maybe we are just showing something, and that's not the case in reality. I know also those psychiatrists that have the contacts from these self-support groups, so we can have in contact with their patients, and that would be useful maybe. Thank you very much, Natasha, for your answer. It seems to me that there's a question in the chat with regards of transgender people. Can you answer, some of the speakers, can you answer this question? If you have any figures or any data about the transgender population, what do you think about that? What can you tell about that?
I don't have the statistics at hand, but there's a very interesting piece of research by a sociologist called Judith Tokacs, who's from Hungary as well, but she doesn't work there anymore. And she has done, together with a group of sociologists and a pan-European survey of the health of transgender people. It's if you send me an email, even through the organizers, I'm happy to forward those materials to you. It's about not just HIV, but it's about general health issues, because it is a problem. It's not as big a problem as it would be in Southeast Asia. But it is a problem, and there are some data, but it's a very under-researched field. So I must admit that there's not a lot of research done, especially not in the east of Europe, where this is a topic that must not even be mentioned. So, yeah.
Thank you so much. Спасибо, доктор Тамаш, что предложили ресурсную помощь. И я, наверное, передам слово организатору.
Thank you very much, Doctor, for making available those resources. And I will give the floor to the organizer of this event, Anastasia Petrova. Anastasia, please let us know, how do you feel, if we cover your expectations, and what are your plans for the near future. It is important to mention also. You have 4 minutes. Thank you very much. I just want to mention my gratefulness for the organizers of this conference. I think that it has been great. Thank you, Rachel. And thank you also our speakers. I think that all these presentations have been really useful. We have received a lot of information, and we have been able to highlight the most important topics. We've been able to get this connection between HIV and mental health. Thank you, Sveta, for your support. I think that we achieve it. And I would like to wish you and all the communities at an international level and at a regional level as well, our donors and all the organizations and all the professionals, to stop dividing, As Dr. Thomas mentioned, let's stop dividing. Let's stop separating the body and the spirit and the psyche. We need to understand that in reality, mental health and HIV are not separate areas. Mental health and HIV are united, are together in one person. So in order to provide a better support, it is important that we need to see the individuals in an holistic approach, in a comprehensive approach. It is a kind of a bridge or liaison that allows us to explain donors as well as professionals and governments, to explain them the need of those services require for mental health and people living with HIV. And this bridge can be that treatment that we give to them, that mental health is one of the most important components of having a successful approach. This is an important factor for people living with HIV, so they live a quality and happy life. So finally, this topic is being covered, and I'm so grateful for that. I'm so grateful that we have had this session. Thank you very much, everybody. Thank you, Sveta. Thank you, Anastasia. This is a great and important conclusion for this session. Let's hope that we have more information and more resources. Please share this session, and many success for your organizations. Thank you very much for this initiative on organizing this session, which is really important for all of us. Thank you.
1 minuta.
2 more minutes, 1 minute. 1 more minute for Tamas, Natasha, Marianne. Thank you very much, Anastasia, for giving us that possibility. This topic is really important, so I hope that we keep on with this discussion further on.
Спасибо большое.
Thank you very much.
Очень интересно было.
1 more minute for Tamas, Natasha, Marianne. Thank you.